Welcome back to this YouTube channel. I'm Dr. Andrea Ferrero, and in this video we'll talk about Achilles tendon pain. Achilles tendon pain is a very common condition, not only among athletes but also among sedentary individuals. It is a pathology characterized by pain, swelling, and reduced tendon function. It's important to immediately clarify one thing. Today, we no longer speak of tendonitis in a generalized sense, but rather of tendinopathy. This is because the problem isn't always inflammatory, but is often linked to a degenerative process and a failure to heal due to repeated overload without adequate recovery. The Achilles tendon is the strongest in the human body, but it is also one of the most stressed. During running, it can have to support loads of up to 12 times your body weight. Precisely for this reason, it is particularly vulnerable to injury and, in the most advanced cases, even rupture, which can be partial or sometimes complete. There are essentially two main forms of tendinopathy: insertional and non-insertional. This depends on the location. Insertional tendinopathy occurs in the area where the tendon attaches to the bone, called the calcaneus, while non-insertional tendinopathy is located along the Achilles tendon, above the insertion. This form of Achilles tendon pain affects the area where the tendon attaches to the heel. It is often, but not always, associated with a deformity such as Höglin's disease, which is a protrusion of the posterior portion of the heel that rubs against the tendon. A link to a video specifically on this topic is provided above. Insertional tendinopathy is the most difficult to treat. Non-insertional tendinopathy affects the portion of the tendon between 2 and 6 centimeters above the insertion on the bone. It is the most common form, typical of athletes, and also the one with the best prognosis. There is not a single cause of tendinopathy, but many causes that can also be associated with each other. In other words, patients may have a combination of one or more of these causes, meaning that treatment for each patient is not the same and must therefore be personalized. There are extrinsic factors, meaning those external to the body, and intrinsic factors, meaning those in which risk factors are present within us. Extrinsic causes include overtraining, improper training, walking or running on hard or inclined surfaces for too long, wearing inappropriate shoes, using incorrect sports technique, and taking certain medications, such as certain antibiotics, including fluoroquinolones, which are antibiotics like ciprofloxacin and levofloxacin. Intrinsic factors, on the other hand, include age, being a problem especially in older people, being overweight, having a high arch, i.e., a foot that doesn't support the center of the foot, ankle instability, reduced elasticity of the calf muscles, and suffering from certain metabolic diseases, such as typically seen in diabetes. There is also, at least in part, a genetic predisposition, the precise role of which, however, remains to be fully investigated. Patients typically complain of localized pain along the Achilles tendon, more or less near the insertion point, depending on whether the condition is insertional or non-insertional. Depending on the degree of tendon inflammation and its duration, the Achilles tendon may be more or less swollen. Many people also complain of stiffness, typically in the morning, which is often associated with one of the intrinsic factors listed above, namely reduced calf elasticity, which is one of the most common causes of chronic inflammation and degeneration of the Achilles tendon. In athletes, pain often occurs at the beginning of a sporting activity, improves during movement, and then recurs after physical exertion. As time passes and the tendon degeneration worsens, the pain tends to become more and more constant, even limiting daily activities. Diagnosis is primarily clinical. The doctor will examine you standing on a transparent platform to determine whether you have a normal foot or whether you have flat feet or a high arch. The clinical examination then continues on the examination table, where the elasticity of your calf muscles, the stability of your ankle, where you are in pain, and how much your Achilles tendon is stretched will be assessed. It is enlarged. Often, especially if the pain has lasted for several months, the clinical examination is supplemented by instrumental tests. X-rays are always very useful, provided they are performed standing up and not sitting or lying down. Ultrasound, which is a diagnostic test based on ultrasound, is reasonably useful, but it is absolutely not comparable to the accuracy of MRI, which therefore remains the gold standard. We finally get to the part that's probably of most interest to you: treatment. Before even discussing treatment, we should actually talk about prevention. This means addressing those external factors that increase the risk of developing this problem, or, if not properly addressed, contribute to prolonged symptoms. I'm specifically referring to the use of appropriate footwear, so I invite you to watch a specific video I made on this topic. Avoid walking barefoot, modify physical activity if necessary to reduce workload, and perform plenty of eccentric calf stretching. In the initial stages, treatment is always conservative, whether for insertional or non-insertional tendinopathy. A generally accepted rule is to always consider surgery as a last resort, and only after trying conservative treatment for at least 6 months. As I'm sure you understand, it's virtually impossible to propose a treatment plan that works for everyone. Nevertheless, I propose this outline, which divides the treatment process into different phases. In the first phase, corresponding to the first 2 weeks, the goal is to reduce pain by trying to reduce physical activity, apply ice to the tendon, and take anti-inflammatories. Subsequently, in what is referred to as Phase 1, between the 2nd and 6th weeks, muscle strengthening exercises are performed, along with essential stretching and physiotherapy sessions, which may also include shockwave therapy. In Phase 2, which runs from the 6th to the 12th week, the goal is to improve endurance and exercise capacity. Shockwave therapy sessions can also be performed, essentially aimed at reducing inflammation and residual pain. In Phase 3, which runs from the 3rd to the 6th month, sports activities can be gradually resumed with increasingly heavier loads. In the final phase, which occurs after the 6th month, other options must be considered. If the pain persists, platelet concentrate injections or even surgery may be considered. However, the reality is that in most cases, patients who come to me have been experiencing pain for several months, so we're not starting from scratch, but rather entering a phase where a more structured treatment is required. The first key point is certainly eccentric stretching. It's the foundation of treatment and must be performed correctly and consistently at least 3 times a day, as it helps the tendon reorganize and regain its function. To do this exercise, simply put on shoes and place your toes on a step, as shown in this video. The second key point is your shoes. Often, the problem arises or worsens from there. I recommend always wearing shoes with a slight heel lift, approximately 8 to 12 millimeters higher than the area under your toes. This reduces tension on the tendon while walking. The third widely used method is shockwave therapy, particularly focal shockwave therapy. This device generates high-intensity acoustic waves that stimulate the body to progress towards natural healing. They are an effective treatment because they stimulate tendon regeneration and improve local vascularization. They don't work instant miracles, but in many cases, they bring significant improvement within a few weeks. You can also find an in-depth video on this topic on my channel. In some select cases, especially in non-insertional tendinopathies, I recommend platelet concentrate, also known as PRP. This is an infiltration that uses the patient's own growth factors to stimulate tendon healing. It's an interesting option when simpler treatments aren't enough. If you'd like a more in-depth look, I've prepared a dedicated video. platelet concentrate infiltrations are obtained by drawing blood from the arm. The blood tube is then centrifuged for a few minutes, after which the red blood cells, which sink to the bottom, separate from the plasma, which remains at the top. It's precisely this plasma that contains high concentrations of platelets. This is why it's called PRP, which also contains growth factors. This plasma also contains a small amount of stem cells. This platelet-enriched plasma is then injected around the tendon to reduce inflammation and pain. It's a recognized treatment with very few risks and side effects. The only drawback, unfortunately, is that it's a treatment that national health services and health insurance providers generally don't recognize, and therefore it's often, but not always, paid for by the patient. Platelet concentrate injections, also known as PRP, are performed in place of cortisone, which is absolutely prohibited on the Achilles tendon. Cortisone, which, as you know, is a powerful anti-inflammatory, can lead to rapid pain relief. But this comes at a very high cost, the risk of cortisone weakening the Achilles tendon, which could then rupture even while walking. These treatments can be combined with physiotherapy to reduce pain and improve tendon function. Techniques such as TCAR therapy can help in the symptomatic phase, but they are certainly not curative and must therefore be included in a more comprehensive program. Surgical treatment is always a last resort and is indicated after at least 6 months of failure of conservative treatment. Treatment varies depending on whether the problem is insertional or non-insertional tendinopathy. As mentioned, insertional tendinopathies are the ones most likely to require surgery, which may involve simply removing bone protrusions from the calcaneus, or even actual osteotomies, i.e. incisions into the calcaneus. Or, when the tendon is severely damaged, it may even need to be replaced with the flexor hallucis longus tendon, which runs adjacent to it. In the case of non-insertional tendinopathies, the risk of surgery is lower. However, in the few cases that require surgery, it may be possible to simply remove the Achilles tendon in the most damaged area, or make small longitudinal incisions along the tendon to stimulate healing. However, even in this case, that is, non-insertional tendinopathies, when the degeneration is too advanced, it may even be necessary to replace the Achilles tendon with a tendon that runs nearby, that is, the flexor hallucis longus tendon. In conclusion, Achilles tendinopathy is a common, often overlooked condition, meaning many patients come to the doctor with a degenerated tendon. It's a slow recovery condition because it's not just inflammation, but a true problem of overuse degeneration. It takes time, proper treatment, and proper management from the outset. Thank you for watching the video to the end, and especially for subscribing to my YouTube channel.